And a very happy good evening to all my friends tonight. Live from Pensacola, Florida, I'm Dr. Randy Fink, and this is Fertility with Fink and Friends. I am Fink, you are friends, and this is the place we are. Every Tuesday evening at this time, 5 o'clock on the Gulf Coast, which means 6 o'clock on the East, and 4 in the mountains, 3 on the West Coast. Fertility with Fink and Friends is the place we get together to talk about all those things that are important, things about making a family, things about pregnancy, things about women's health. Here we are to answer all your questions, and I am so excited to be here as always. I am a fertility gynecologist at New Life Fertility in Pensacola, Florida. We also have offices in Mobile, Alabama, as well as Panama City. And I work with the fine folks at the Missouri Center for Reproductive Medicine, that's MCRM, in St. Louis and in Tulsa as well. And yes, we can see you no matter where you are. We've got friends here who watch from all over the country, all over these great United States. And yep, we can talk to you anytime for a virtual visit with a camera, or we can do it on the phone. We're happy to help you with your cycles if you're going through IVF. If you're struggling and you just need a little word of encouragement, that's what we're here for as well. A special shout out to Hi Baby Love 88. Good to see you here. Looks like Lil Jax. Hey, how are you? Nice to see you here tonight. Kowser, good evening. Priest Lana, you are number one here for me tonight. Thank you for joining. Sheila, 125, how are you tonight? And thank you for the kind words. Looks like Mohammed Niha. It's nice to see you here as well. We've got a couple of different feeds here. So this is my Instagram feed, and that's Randy Fink MD. This is New Life Fertility right here. We also have MCRM Facebook. We have New Life Fertility. We have the First Fertility Network, of which we are a proud member. We've got LinkedIn. We've got YouTube. We have all manner of social media to connect with you here tonight. So if you've got questions, we've got answers. Lay them on me. This happens to be this is Retrieval Week here at New Life Fertility in Pensacola. So we're doing IVF retrievals this week, and of course that means that we have stimulated ovaries over the course of the last 9 to 12 days, and we are retrieving eggs this week. Good evening, Dr. Noreen. Thank you for being here, who I will say is one of the finest internists I know. And I think, yeah, you were actually in the office today, and you didn't even stop by to see me. So duly noted, ma'am, duly noted. A big shout out here to the Bama gal and husband. That is my wonderful mother and father in Mobile, Alabama, who are watching tonight, as they so often do when they remember who I am, is what I mean by that, because sometimes, they forget. My brother is in town, I think visiting. If he's already there, I think he landed in Mobile a little bit earlier, and is coming all the way from the great New England, from Boston and from the Maine area, to come and visit with the folks down here on the Gulf Coast. And so welcome to town, Jeff. And Robbie says, oh, I didn't make it today. That's right. You were a no-show for your visit. That's what it was. That's why you didn't come to see me. Well, tomorrow is a new day, friend, and don't let it pass by without saying hello to the Fink. You know what I'm saying there? All right, so let's see. If you've got questions, please throw them my way. But the first question here comes from Corrine. And Corrine says, I'm thinking about saving my eggs. What does that entail? Well, that is a very good question, wouldn't you say? Egg freezing, or what we also know of as oocyte cryopreservation, is the process whereby we stimulate your ovaries to get you to produce as many eggs as we can. So under normal circumstances, as you know, the ovary will produce and release generally one egg in a given cycle. And that's what we know of when I say cycle as a menstrual cycle. And so that egg goes on and gets released. And if a sperm comes along and fertilizes it, then that's what creates a pregnancy. Well, when we stimulate the eggs in the beginning of the menstrual cycle, the brain tells the ovaries, give me a bunch of eggs. And the ovary says, I. And so it dips down into its well and it pulls up a bunch of little egg houses. And these egg houses are called follicles. They are quite literally a little tiny sac of fluid with a microscopic egg on the inside. So we can count that number of little follicles in the beginning of the cycle. That's called an antral follicle count, and that gives us a clue as to how many eggs we might be able to retrieve from your ovary in that given cycle. Normally what happens is that these eggs will quite literally fight with one another because one of them is trying to emerge as the victor, as the leader, as the alpha, as the dominant egg. And that dominant egg goes on to be the one that gets released. Well, what happens to the rest of them? They disintegrate. They just kind of disappear into the body. And none of them really want to disintegrate, so they fight it out so that one can emerge as that dominant egg. Well, the goal with IVF is that we are trying to stimulate to retrieve all the ovaries in order to retrieve all of those eggs so that we don't get one dominant, but so that they all grow together synchronously so that we can retrieve them and then put them to use. In the case of egg freezing, what we're doing is that we are retrieving those eggs and then we're very quickly doing a process that's known as vitrification. And vitrification means freezing. It means making a little nick in the outer sort of shell of that egg, if you will, and taking the water out of those cells. Because these are going to get frozen at minus 157 degrees centigrade. That's pretty cold, and so what we do there is you want the water to be out of them because that water will of course become an ice crystal, and that ice crystal can damage the very fragile little egg. Eggs are just a single cell, and so they are indeed quite fragic. Where'd that word come from? Quite fragile, and so in order to be able to save them to use later on, that's how they're frozen. And so what happens from there is, well, maybe you need them, and maybe you don't. Really, what you're doing when you're doing egg freezing is that you are really buying a fertility insurance policy is the way I like to think of it. Because you may never need those eggs. You absolutely can potentially get pregnant in the normal way. But if time goes by and you're having a difficult time getting pregnant, or you can't find the right partner, or whatever the issue may be, the younger you are when we retrieve those eggs, the greater the probability that the genetic material in those eggs will be normal. And we want those eggs to be normal because you need a chromosomally normal egg in order to produce a chromosomally normal embryo. And you need a chromosomally normal embryo if you want a baby, because that's what sticks and that's what grows. So the goal of egg freezing is to be able to retain the ability to use your own eggs at any point later on in life, because as each year goes by, the genetic material in those eggs becomes more and more fragile. It becomes less and less stable, such that it ultimately becomes difficult for us to be able to get pregnant. We also lose those eggs over time. So two good reasons that as we mature, it gets harder and harder to have a baby. So that's the goal there with egg freezing. And a special good evening to Randy. Nice to see you. You got me a little choked up there for a minute. Gosh. Let's see. And there's a question here about please talk about blastocyst hatching after embryo making. All right. Well, so let's just say, hypothetically, that you went through the process of IVF and we got some eggs, or even hypothetically, we froze some eggs for you, and then you decided, well, now I'm ready to be pregnant. So what we do is we thaw those eggs. We have the sperm that has been provided either from your partner or from a donor that you've selected. And they take one single sperm. So first what they do is they run that sperm through an obstacle course. And the goal of the obstacle course, like any obstacle course, is that, well, you got to jump over all the little, all the obstacles in order to get out the other side. The first group of sperm to make it through that obstacle course are going to be the strongest. They're going to be the best swimmers. They're theoretically going to be the most normal of the sperm, right? So our embryologist will then sit down with that group of embryos and look at them under the microscope and select one single sperm for each egg. We take that sperm and place it inside the egg, and that's fertilization. That process is called ICSI, I-C-S-I. ICSI stands for intracytoplasmic sperm injection. And so that's how an embryo is made. So then we look at those embryos the next day to see which one's fertilized, which one seems to have done what it's supposed to do and started to grow. It started to grow into a little tiny human being. It starts out with just a couple of cells, and those cells multiply. 2 become 4. 4 become 8. By the time you're at 3 days old, this embryo, it's got between 6 and 8 cells. But then it goes through this massive undertaking between day 3 and usually day 5. Day 5 is what's known as a blastocyst. And by the time that embryo becomes a blastocyst, it's got between 150 and 250 cells. So from 6 to 8 cells all the way to 250 in just a couple of days. If it makes it that far, then we know it has a higher probability of being chromosomally normal. And again, we want that chromosomally normal embryo in order to make us a baby. So what happens there is now we've got these blastocysts, and what we've done is that we have used nature to help us select that first group of embryos that has the higher probability of being normal. And we can take that another step, and we can do some testing on those embryos. We can actually take some little cells from the outside part of the embryo, and that's the part that's going to become the placenta. Take a few cells from there, and that's called PGTA, pre-implantation genetic testing for aneuploidy. Aneuploidy literally means abnormal chromosomes, and we can test the chromosomes in those embryos. And when we get a chromosomally normal embryo, that embryo has about a 65% probability of being able to get you a baby. And that's the best numbers that we can hope for in terms of IVF. So there is this thing that's called artificial or really assisted hatching. And so think about a hatching egg, right? We've all seen, at least in the cartoons, a little chicken kind of coming out of the egg, and maybe you've seen, maybe you've seen a real one, or maybe you've seen a little video. A little baby chick or a baby bird coming out of its shell. It literally breaks that shell, and it kind of comes out. Well, one of the things that has to happen with an embryo when it is going to implant inside of you is that it needs to hatch. Assisted hatching is where a little tiny nick is made in the cellular membrane that we might call a shell, so that the embryo can begin to hatch. And as the pieces of that embryo start to come out, it's those little tendrils that will implant inside the uterus in the uterine lining, which we also know of as the endometrium. So that process of assisted hatching is something that's done pretty routinely with embryos. Now, when you grade an embryo, and grading an embryo is not the same thing as sitting through math class and maybe getting a C, or maybe doing a little better, or maybe doing a little worse. It's not that kind of grading. Embryo grading is what happens when the embryologist sits down with the microscope and uses a particular scale to be able to describe certain features of that embryo. So one of those features is how hatched the embryo is. A hatching embryo is a stage 5. So if you've seen a 5AA or a 5BB, that first number has to do with the state of the hatching. So a hatching embryo becomes a stage 5, and so that makes it, in theory, a better embryo. Now, we don't want it necessarily all the way hatching, which might be a stage 6, because then it might become a little bit more fragile. So the ideal number that we're looking for there is a stage 5 or an assisted hatching embryo. So for example, a 4AB embryo. Stage 4 means that it's perfectly round. It hasn't started to hatch yet. Now, in many cases, what'll happen is that that grade is assigned when the embryo is frozen. So once it's thawed, it starts to grow again, and in many cases that stage 4 embryo will become a stage 5 embryo. It'll start hatching. So when you come in for your embryo transfer, we're going to give you a picture. And in that picture, you may see what looks like something that's kind of bursting forth from that embryo, and that is that hatching process. So normally we don't actually upgrade the embryos because it doesn't change anything really at that point. It's all just a question really of nomenclature. However, it's very common that we see an embryo that's starting to hatch, that is hatching by the time we actually go to do that embryo transfer. And that is a wonderful thing to see, and that is what you will hopefully see as well. And that's a little bit about embryo grading and a little bit about hatching and about how that whole process works. Now, Corinne had a follow-up question here, and that was, what are the criteria I might use for donor sperm? Well, medically speaking, there's really only two things that are the most important. One is all these donor sperm donors, I should say, have been tested for genetic diseases that they might carry. We have a very colorful, as I like to say, we have a colorful genome, which means to say that we carry a lot of different things in our chromosomes. Most of them are buried. Most of them really don't have to do a whole lot with our lives unless we happen to carry the same thing as our partner. And so we can do a test for hundreds of what we call autosomal recessive genetic diseases, which if you happen to be positive for and your partner happens to be positive for, it gives you a 1 in 4 chance of having an affected baby. And the time to find that out is before you get pregnant, because we can prevent you from having an affected baby, which sounds like a pretty good idea if you ask me. But so we identify what you happen to be a carrier of, and then you go and look at the sperm bank, which will list what these donors were carriers of, and you just make sure that you're not carriers of the same thing. That's a pretty easy one. The second thing that we look for when choosing a sperm donor is the status of your CMV. CMV stands for cytomegalovirus. Cytomegalovirus. Most of us as adults have been exposed to CMV. And CMV is kind of like, it kind of would feel like it's a bad flu. It's just a viral illness. But if you contract it when you're pregnant, it can be really catastrophic on a pregnancy. It is, for example, the most common cause of congenital deafness in offspring, CMV. What we want to know your status for is that if you are like most adults and you have been exposed to CMV and you are immune from CMV, then it doesn't matter about the status of your sperm donor. But if you are CMV negative, meaning to say you are not immune from CMV, you've never had it, then you want to pick a donor who is CMV negative as well, because there's a theoretical risk that if the donor is CMV positive and you are CMV negative, then that sperm could infect that embryo from the very moment of fertilization. So being CMV positive or immune means it sort of opens up a whole other host of different donors that you can use, because again, if you're CMV positive, you can use either a positive or a negative donor. But if you're CMV negative, then you use someone who is CMV negative as well. So let's see who else here. Desi Banks, good evening to you. Hi, Marlena. Hello, Ruger. Nice to see you here, Aaron and Randy. Let's see, we've got Dragon Meyer. We've got the wonderful and talented Miss Foxy Angelina up in the great state of Minnesota. Donna Spicer is actually here this evening, and that is a very exciting one. Haven't seen Donna for quite a while. Let's see, it looks like Shadia is here. We've got Mira is here. Winnick is here. Good evening to you, Elsa. And Bryn Holm, hello, my friend. Bryn says, Neupogen is so expensive. Does it make a true difference during an FET? And my answer there is probably not. Probably not in most people. And in my world, there is a very narrow indication for using Neupogen, and that is actually in someone who had a difficult time building their endometrial lining, because Neupogen will actually help with a uterine lining. We can also use it in some cases of recurrent pregnancy loss by doing an intrauterine wash with it. But there are some programs who use Neupogen routinely in a sort of catch-all immune type protocol, thinking that, well, it's going to help someone, but rather than testing everybody, it might not hurt anybody, so therefore we can just use it. And the American Society for Reproductive Medicine recommends against doing those sort of kitchen sink approaches for most people, but precisely because Neupogen is very expensive, and what it does is that it causes your white blood cell count to skyrocket. It makes people very nervous when they see those results. You know, your normal white blood cell count may be 10,000 or so, maybe even less than that. If you're sick, gosh, it can get up to 12, 15,000. Your white blood cell count becomes 40,000 or so when you're using Neupogen. So I don't typically use it unless it's for that very specific indication. It is not something that probably works it is not something that works for everyone, but it's something that some programs will use because we know that, well, it may work in some people and it may not harm most people, except for perhaps at the level of the checkbook. And so that's kind of why it's used there. I missed a couple of folks over here on the New Life Instagram side. I didn't say hi to Angela Sack. Good evening, Angela. It's nice to see you as well. I don't think I saw you in the last couple of weeks. Haley26 is here as well. Let's see, we had another question here from Kowser. My vitamin D level was 25. My Thorne prenatal has 1,000 IUs, which is international units, and I'm taking an extra 2,000 daily at 12 weeks. Should I continue the extra dose or only the prenatal? Well, that's a good question, and I'll tell you that the whole vitamin D thing there is really an epidemic of vitamin D deficiency. Now, why is that? I don't know that anybody has an answer to that. When I lived in Miami, and I took care of a lot of, just as a gynecologist, lifeguards, from Miami Beach, people who spent all of their time outdoors were still vitamin D deficient. We get our vitamin D from the sunlight because it converts in our skin and becomes the vitamin D that goes to work inside our bodies. But why are we all so vitamin D deficient? Well, I think, you might say as a population, we don't spend as much time in the sun anymore. We use products that protect us from the sun. Otherwise, you end up looking like me, like an old lizard man, and with skin cancers and all kinds of other things. You don't want my dermatologic history. You really don't. So the number that we look for in vitamin D, the lowest level of normal is a 30. And do you know what that number 30 actually represents? It represents the lowest level of vitamin D that is used to prevent rickets. And rickets is a musculoskeletal disease that comes from absence of vitamin D as it pertains to calcium and what your body is able to do with it. So in the anti-aging community, the optimum vitamin D level is between a 60 and an 80. So there have been studies that look at longevity and certainly at egg quality and embryo transfer outcomes. And we like to see numbers that are at least normal, but to be honest, I like to see between 60 and 80, still kind of being in that anti-aging sort of business. So what does it mean if your number is a 25? Well, I really like to see you on 5,000 units a day. Using 1,000 or 2,000 or 3,000 is really probably not enough to truly move the needle in most people. And my dear friend Dr. Noreen here says that it's not about getting enough sun, it's about the ability or the lack thereof to be able to absorb it into the system. And that's really the key thing, that if you're taking only a very low dose, like 1,000 or 2,000 or 3,000, you don't really absorb enough of that to really truly make a big difference. So I kind of feel like 5,000 is really the minimum dose that I put people on, because there over time you will start to see that needle move. Now, alternatively, there are some people, when your level is low, they may prescribe you this once weekly 50,000 unit pill of vitamin D to take. Now, and that sounds like a lot of vitamin D, and guess what? It is. In my experience, we just can't absorb that much vitamin D at once. And so my choice for vitamin D3 is to use it with vitamin K, because vitamin K increases the absorption of vitamin D. There's a liquid D3 with K2 that I am very fond of. And in fact, there was a study called the Rotterdam trial where they looked at what does that vitamin K do in addition to helping the vitamin D levels. And they found that it cut the plaques in the coronary arteries. It cut the plaque risk in half, and it cut the risk of cardiac death by 50%. Vitamin K2 with your vitamin D. So there's a little something special for you. That's your free tip for the evening. Get on some D3 with K2, would you? Let's see. So at 12 weeks, should you continue the extra dose? I'd say I'd really like to see your level be a little bit higher than just 30 would be my recommendation. That's the way I like to look at it. Okay, Marlena asks, any tips on how to prevent that progesterone in oil from leaking out after the injection? And I have something to say about that, but before we get there, let's take a pause to do something that I think is very important. It's 1:30 now, and if you're just joining, I'm Dr. Randy Fink in Pensacola, and this is Fertility with Fink and Friends. At this point in the show, I'd like to take a moment to just give a nod out to all those folks out there who are struggling, because the fertility journey is a difficult one. But it's not just about fertility. It's about all those challenges that life throws our way, which sometimes can seem to be so very unfair. Life is not a fair place. Life is a place that can be full of pain and a lot of obstacles and speed bumps. And when you have to face those things, it often feels very frightening. It often feels very isolating. It can make you feel very much alone. This is the point in the show that I call it the 5:30 Fuzzies with Fink, where we can send some warm fuzzies out to everybody tonight who needs to know that they are not dealing with this world alone. And whether that is as part of this fertility journey, whether that is something pertaining to work or school or love, relationships, whether it's about family or even if it's just about kind of how kind or maybe not gentle you are with yourself on a day-to-day basis. Whatever you're going through tonight, you're not alone. These folks who watch my program tend to be people who would give the shirts off their backs in order to just let you know we're in this together. So if you could take a moment and I always say, break the internet with kindness by sending out those positive vibes to people tonight who need to know that they're not alone, that other people have faced this same difficult road and have made it through to the other side. That's an important thing. Tomorrow, maybe do some random act of kindness, smile at a stranger, do something that makes people know that you're here to change this world, even if it's just one heart at a time, one mind at a time. We can make a difference. Be there for someone and know if you're the one on the receiving end that you're not alone. And that, my friends, is the 5:30 Fuzzies with Fink. I hope you feel all warm and fuzzy now, because I certainly do. At least I'm fuzzy, so it's the best I could do on short notice. But you know what, honestly, I think that's, people say, are you being sincere with that? And yes, Aaron, I am being sincere with that, because we all are on this earth for we're not really around here for all that long. So anything that we can do to try to affirmatively, positively change someone else's life means that we have made a difference in that little bit of time that we're here. That's what I strive for, and I hope that you will as well. So that said, hi to Jessica out there in the Facebook land. Jessica says, I've been prescribed 50 milligrams of naltrexone, for 21 days before next retrieval. I've seen info on low-dose naltrexone, but not full-dose naltrexone for help with the pituitary gland and egg quality. Has there been a lot of luck with this approach? 50 milligrams, I have never seen that dose used. That's full dose naltrexone, and I wonder if that wasn't some kind of mistake, if that wasn't an error, because I will uniformly use 4.5 milligrams, and that's low dose naltrexone. High dose naltrexone will completely block your opioid receptors, and there are certain indications for that, but low dose naltrexone partially blocks the opioid receptors and temporarily blocks your opioid receptors. And when that blockage goes away, it has a reflex increase in your endorphins. And those endorphins are a stimulant for your immune system. The good parts of the immune system it stimulates, and the bad parts of the immune system it suppresses. So low-dose naltrexone has been around for a very long time, particularly in the anti-aging community. I also use it quite a bit as a kind of a generic immunosuppressant for people whose immune systems are all activated, and we use it very commonly for folks who have a diminished ovarian reserve, or when we have concerns about egg quality. But in a dose of 4.5 milligrams, I have never seen full dose naltrexone used for that purpose. So it makes me wonder if somebody didn't accidentally put in the wrong dose. And I think that that's probably worth a phone call, Jessica, because I think that's an unusual one. I hope that that helps. Kelly Lee is here as well. Hi, praying for everyone, Kelly says. Everyone in here going through this journey, we are counting down the days until our transfer next week. Kelly, I am excited for you. We all have our fingers crossed. This is going to be a good one. Yes, indeed. And thank you for those prayers. I think it really does make a difference there. We've got Green Rock here, the legit Brit. Haven't seen you around for a while. Hello, Noodles. Good to see you this evening. Sharf Nap, thank you for being here. Priest Lana says love and kindness to everyone. And Kowser says a thank you as well. And hi to Heather K. Hi, Heather K. Hi. Hi, Heather K. It's good to see you here, too. Let's see. I got a question here from Nettie that says, can I transfer my embryos to you? The answer is why, yes, you certainly can. We'd be happy to help. So when embryos are frozen, they're cryopreserved. That puts them basically puts them onto pause. It stops what they're doing. It stops them in time so that they are there for you thanks, Marlena. I did forget. She says, don't forget those tips for the PIO. Yeah, you're right. I completely forgot. Thank you. We'll go back to that in 1 second. When the embryos are frozen, as I was saying, it stops them in time. When they're frozen, they can be shipped any place. So what's common for us to see here in Pensacola, we have an awful lot of military folks, and maybe they're here for a few years, and they make some embryos, and they get a child or maybe two, and then they move on to a next station, or perhaps they retire from the military and they go and they live somewhere else, but they still have those frozen embryos. In our case, those embryos are shipped to a facility that does nothing but freezes, cryopreserves, or at least holds those cryopreserved biological specimens. And so there are some programs that do their own freezing. There's obviously there's always concerns with that. What happens when the power goes out? What happens if a hurricane comes? What happens if an earthquake hits? So usually these cryo facilities are able to keep things in relative safety. But it's fairly straightforward to ship these things. They put them in a cryo container, which kind of looks like a little R2-D2, and they get picked up by FedEx or UPS overnight, and they're shipped. Those shipping containers, the little R2-D2 looking things, they can keep specimens frozen usually for at least 7 days, and there's some of them that will keep them frozen even up to 30 days I've seen. And so, if it's accidentally left out on the tarmac in Memphis, it's still safe. Is it safe to ship embryos? Yes, it definitely is. And so no matter where you go, so even if your next duty station is in Anchorage, Alaska, yes, you can ship your embryos there in order to go through. Now, I don't know, actually, in Anchorage, I don't think that there is a fertility specialist there. So maybe you can't do an embryo transfer there, but you could ship your embryos. So that kind of doesn't really help. But yeah, they can pretty much go any place. All right, so forgive me, Marlena, but tips for keeping the PIO, for doing that PIO injection. So the first thing that I recommend is that, the progesterone in oil, it even sounds barbaric, doesn't it? It sounds like, your poor booty at the end of that is like, oh gosh, I know people who still have knots in the muscle in their butt where they had to do that intramuscular injection for all that time. So here's the thing. You want to make sure, so first thing that I do is I would say put a cold pack on it, because the cold pack not only sort of makes it a little number, it lets your nerves experience that cold, and so the nerves are occupied with experiencing cold, so you don't feel the injection quite as much. That's called the gate control theory of pain. That's why if you bang your elbow, you go, ah. And you do this because you're occupying the nerves with something else other than that feeling of slamming it into the table, or you stub your toe, or whatever that case may be. So put the cold pack on it because that definitely helps. When you do the injection, you want to make sure that that injection is going into the muscle, that it's not going into the fat. Now, we all have a fat pad that sits over top our gluteus muscle. And that's not a judgment on anyone. That's not saying anything about anybody. We all have a fat pad. But if that progesterone and oil gets into that fat pad, then what will happen, or what can happen, is that it can create an inflammatory response in that fat pad. It can start to kill off some of those fat cells and create something that's called fat necrosis, or traumatic fat necrosis. Which can then scar and leave what feels like a knot, a hard ball in that area of fat, and that can stay there for I mean, honestly, I've seen people keep those fat necrosis areas for years. So you want to make sure that you're getting the needle all the way into the muscle. And so the other thing that happens when you're putting the cold pack on it is that you're shrinking down all the extra little blood vessels that are there that are otherwise really richly causing that muscle to keep oxygen flowing. So when you put the cold pack on, it shrinks the little blood vessels. And so when you do the shot and it's all the way in the muscle and you finish the shot before you pull the syringe out, a lot of people, they're just so anxious to get that syringe out, they are still injecting a little bit as they're withdrawing. That's the number one reason that progesterone and oil leaks out afterwards, that it just wasn't all the way down into the muscle. Now, you may still get a little bit of leakage anyway, and that's pretty much okay. But the cold helps too, because when you're using warm there, if you put warm on it instead, then that's increasing the blood flow to it. You're going to feel it more, and it's more likely to kind of help push things out immediately afterwards. Now, if it's sore after about 15 minutes, then, and I still think cold is a good thing to use there, then you can use some heat because it's less apt to kind of push that out and make the soreness, really kind of even worse. So hopefully that is helpful there. Keep the needle all the way into the muscle. Take your finger off the plunger before you pull the needle out. Best advice I could give. Let's see, Kauser says, Doctor, I previously had to take 4.5 milligrams of low-dose naltrexone, and after conceiving naturally, I stopped at 12 weeks. Yeah, I usually keep, and folks I put on low-dose naltrexone, I usually keep on through the first trimester because the risk of spontaneous miscarriage, goes down after about 12 weeks. So anything we can do to sort of keep things quiet at that point, I think is probably a good thing. There is no science to how long you take it. I know there are some programs that tell folks to take their low-dose naltrexone all the way through pregnancy, but that can be a double-edged sword. First of all, there is no good evidence as to whether it's safe, and it probably is, but it hasn't really been studied, or whether it really truly does anything. So that's safety and efficacy, the two things that we think about when we want to use a medication. The other concern is that if you're taking naltrexone, when you go into labor and it's time to put some fentanyl into an epidural, for instance, well, you may be partially blocking some of those opiate receptors, so you don't get the same kind of pain relief that you do if you weren't on that naltrexone, because you're blocking those receptors. So I don't advocate taking it throughout pregnancy. I usually recommend that most people can stop it really at 12 weeks. Let's see, else is here from Oklahoma. Hello, my friend from Oklahoma. How often have you done a fresh transfer on a 36-year-old? I'm asking for myself. I have a very thin lining. The only time my lining has ever been above 8 is after retrieval. So there's no harm to doing a fresh transfer. So yeah, when your lining gets to be, with stimulation, we see that you're kind of really maxing out on what your estrogen levels are going to be, because you're getting that medication. That medication is causing you to make estrogen, or rather is causing you, yeah, it's causing your follicles to grow, and those follicles make estrogen, and that estrogen builds your lining. So a fresh transfer in many places is said to have a little lower success rate compared to a frozen embryo transfer. And that it's really counterintuitive to a lot of people. A lot of people think, well, wait a minute, hold on a minute here, because frozen vegetables are not nearly as good as fresh vegetables, so the same thing really must hold true with embryos. And the answer is not so much, because when you've done that stimulation, what happens is that your body is really focusing on making eggs. You are a professional egg maker over that couple of weeks, right? Much more so than you are a professional at getting pregnant part. There are some times that we see some numbers that tell us, nope, you know what, this isn't going to work. And we say, don't even think about a fresh transfer. If you have polycystic ovarian syndrome, for instance, more often than not, you create a situation where hormonally your body is just not hospitable to being pregnant at that same in that same cycle. But other people can do a fresh transfer. In our program here, the success rate with a fresh transfer is really very, very similar to that with a frozen embryo transfer. So we don't mind doing them. Age is not a contraindication, Elsa, to a fresh transfer. So I would say by all means, you should definitely give it a try. Yep, talk to us about that. Now, sometimes there's a little bit more of a logistics issue when it comes to fresh transfers. We may want to, and especially if you're in Tulsa, the embryo can't go back to Oklahoma from St. Louis. The embryo would stay, which would mean that you would do your fresh transfer really after your retrieval in that next week in St. Louis. So do you go home? Do you come back? That part's up to you. So there can just be some logistical concerns depending on which clinic you are using. A special good evening to Zenaida in South Florida. It's wonderful to see you. She says, good afternoon, Dr. Awesome. Oh, you say all the right things. Please stop. Okay, one more time. One more time, just once more. Thank you. Haley says, so wait a minute, hold on. Heat is okay after progesterone and oil, and thank you for the transfer yesterday. Fingers crossed there, friend. And thank you, Robbie, for sending such good vibes along with you. You have such good energy, my friend. So Haley, yeah, you can. So here's the thing, like I say, I wouldn't want you to put heat on it right away, because while heat does increase the blood flow to it, it can actually make it a little bit more sore and can actually cause a little bit more leakage out of the site where you injected. So I would say a little bit later on, after it's calmed down a little bit, if you feel like you need to, then yeah, you can use heat. But from a soreness standpoint and from a pre-injection standpoint, use cold. Yeah, for sure. Lisa, good evening, my friend in St. Louis. It's great to see you here. I appreciate you stepping on to join us. Just to follow up with Haley, the cold isn't helping after my injection site from yesterday is still hurting today. Yeah, I will say that the medical term we use for progesterone and oil is, I would say, it sucks. It really is. It's not pleasant. It's a big, thick, viscous liquid that goes into a sensitive muscle. And yeah, I mean, it can cause, you can get a bruise down in that muscle as well. And that's one of the reasons why when you place the needle into the muscle, you pull back on the plunger a little bit to make sure that you're not in a vessel. So it's not such a big deal that, oh gosh, you put progesterone into a blood vessel, because it's going to get in your blood vessels anyway. And there's no big vein or anything back there that you're going to stick it into. But the other, kind of concern there is that, well, if you're right on top of a vessel, you're much more likely to end up with a bruise. And it may be on the skin or it may be kind of deep down in the muscle there. And that will make it continue to hurt. Now, I personally have not had to use progesterone in oil. Um, um, for what I hope are obvious reasons. But those of you who have used it before, correct me if I'm wrong. One, it sucks. Two, though, your body does get used to it. You get a little more accustomed to being able to give yourself that shot, or if someone is giving you that shot, it gets a little easier as time goes by. I do have people who say, well, gosh, what happens? I'm going to have a real hard time giving myself a shot, and my partner doesn't want to do it. They're not comfortable with it. Almost everybody knows a nurse or a medical assistant or a paramedic. I have had folks who will go into the office every time for an injection. That's kind of a lot to do. You can go to the fire station. You know what? The paramedics will happily give you that injection, or one of the firemen, they can do that if they're willing. Many places are. So there are ways around it, but the good news is there, Haley, that it doesn't stay quite as brutal. Marlena says it definitely gets easier, like you said. It gets easier, but that doesn't mean it's easy. Because you know what? If it was easy, everybody would do it. And you are the special one here, right? Absolutely. Marlena, thank you for that feedback there. Does a GLP-1 before transfer help? Well, so the GLP-1 medications are a good thing in general. Yes, they are a good thing because they do decrease inflammation. Many of the inflammatory markers that I'm accustomed to looking at, especially in folks with metabolic syndrome type issues, they are miraculously better. People's what do you call it? I'm sorry, I just heard a siren right outside and it distracted me there. People's inflammatory markers improve, their hormones get better. A lot of times people who are, go on the GLP-1s, they start to lose weight, their hormones correct, and then they spontaneously get themselves pregnant. Now, you're not supposed to get pregnant when you're on the GLP-1 for 2 months. It's supposed to be 2 months, so says the FDA. But yeah, I'm a big believer in the GLP-1s because I really see it do a lot of good things for people's bodies, for the hormones, for the inflammatory markers. Very nice thing. Meg Johnson, hi, and Tara, good evening to you. Fraley, hello, and Peachy, howdy, Peachy. Mariel, nice to see you here this evening as well. Let's see, so here is a good question. What about, atypical question, what are your thoughts about getting a breast augmentation while doing an embryo transfer? So I would say the answer to that is, so you can definitely look into it, but here's what I hope will happen. You're going to, so first of all, there's no good reason to get all that anesthesia in your system in that very same cycle where you're about to get pregnant. I would really rather you not do that. The other thing that's going to happen is that it takes a while, for breast augmentation to recover, for it to completely heal, for the swelling to go down, for some of the immediate autoimmune effect of encapsulation to kind of start to get better. And as you know, once you get pregnant, one of the very first signs of pregnancy is going to be that your breasts start to get sore and they start to get bigger. And they are going to get bigger with your pregnancy. And if you're still recovering from that breast augmentation, there ain't no telling how much misery you might be in from those really sore and really, really large breasts. So the other thing that happens is, of course, as we go through pregnancy, the suspensory ligaments that hold the breast in place start to stretch. And this is another thing that just kind of happens with age. But this is why those breasts may be here now. They're going to get larger with pregnancy. You might breastfeed afterwards, and so you just kind of want to make sure that the type of augmentation doesn't prevent you from doing that. But then once things shrink down, those ligaments that are holding the breast there, they have been stretched. And so that's why the breast starts to fall a little bit more. And people talk about their breasts, think about needing a breast lift even at that time. Now, sometimes an implant can accomplish the same thing as a lift depending on what you have going into it. But when immediately trying for pregnancy is generally not the best time to be going for a breast augmentation, because again, hopefully very shortly after that FET, you're going to be pregnant, and then everything is going to change. So the other way to look at that is it worth spending that much money to get what you think of as perfect breasts, only to then have your pregnancy change them inexorably, where then maybe afterwards you might want to do something else. Now, here's the other news. People talk about, hormones. Hormones must be so bad, and hormones this and hormones that. Did you know that about 50% of women who have a breast augmentation end up having more surgery on the breast for cosmetic purposes? Or maybe it's to remove the implants, or maybe it's for a lift, or maybe it's to change the implant, or something. 50%, 1 in 2, I am told, end up having additional surgery. That ought to be a headline that's on the front of the newspaper, because that's kind of a big deal. So I'd say wait until after pregnancy is probably a better time. Angela asks, how many months do you need rapamycin before an egg retrieval? So rapamycin is also known as sirolimus. It is a medication that is used experimentally for egg quality. There's some pretty good studies in 2025 that looked at a particular protocol starting 21 days before the start of stimulation and ending with the trigger shot. However, and that seemed to really make a difference in the outcome. It made for better quality eggs, and it made for better quality embryos. The problem I have with that is that the biological mechanism for that doesn't make sense to me. That I feel like it makes a lot more sense to try to repair those eggs, let's call it 60 days, before you can start that stimulation. So I've tried both ways. I'm still not, if we've got the time, let's say if someone wants to do my next cycle and I have a concern about that egg quality, I'll say, let's do it, the way the study did it, which was 21 days before stim start, and then stopping, with the trigger shot. But if we have some time, let's make that time worthwhile. Take your supplements from the list. That rapamycin, I use probably 3 days a week at that point, and then kind of give a little boost right at the end of it. It's not something that you really need to take every day. So that's kind of how I do it. There's still, it's still considered experimental, so we don't have great guidance on exactly what works. And the other part about this in the fertility thing is that what works for somebody is probably going to be different for somebody else. It's never necessarily, kind of the same problem, but, or at least not the same solution. So that's my thoughts there. Hey, Amber Watson, good evening to you there, my friend. Folks, we are going to run out of time tonight. Oh my goodness, the time just flew right by here. I am so happy all of you were able to join me this evening for Fink and Friends, because I am Fink and you are my friends, and I really appreciate you spending a little time with me here this Tuesday evening and every Tuesday at 5 o'clock Central Time. Fertility with Fink and Friends is broadcast live from Pensacola, Florida, where I am a fertility gynecologist at New Life Fertility in Mobile, Pensacola, and Panama City, and also at the Missouri Center for Reproductive Medicine in St. Louis and in Tulsa. Remember, kindness makes all the difference in the world. Every step forward with kindness, every step forward with love, and every step forward with hope. Because tomorrow is a new day, and it's full of all new adventures. So until next week, thanks so much for being here, and good night.